Alright, so now after our last discussion of all the different kinds of syncopes, we had gone back to the cardiovascular chapter to finish up more syncope practice questions. We wrapped all that up, and now we're up to disorders of the neuromuscular junction. Now, this stuff often gets tested alongside with musculoskeletal system problems. So you'll often see things like what are they like? Fibro, I think it was fibrodysplasia, and then there's one other, two different muscular disorders that actually cause pain throughout the body. There's also, right here, these two guys. So fibromyalgia and polymyalgia rheumatica. Those two are also muscular pain disorders that are also going to get tested pretty frequently, right? So those are topics from musculoskeletal, and then polymyositis and dermatomyositis, as well as the seronegative arthropathies. There's muscular pain in those guys also. So those are also going to be other answer choices that are going to be basically differentials you'll have to work with when you're trying to solve these questions, right? So myasthenia gravis right here, first thing, autoimmune disorder caused by antibodies that bind to postsynaptic acetylcholine receptors located at the neuromuscular junction. Most often affects young adult women and older men, and can be associated with thymoma, thyrotoxicosis, and other autoimmune disorders. So we're going to be comparing myasthenia gravis as well as Lambert-Eaton. So let me actually find both guys here real quick. Yeah, okay, so you can see in step one, actually, all the topics are discussed in a continuous manner, right? So they talk about polymyalgia rheumatica, fibromyalgia, the poly and dermatomyositis, and then boom, neuromuscular junction diseases. So those are all guys that go together as differentials, and they're all going to be answer choices for every question. Every question that has one of them as an answer choice will have all of them as an answer choice. And you're really going to have to differentiate based off of very minuscule little physical differences, differences in how the pain comes and goes, or any antibodies that you might find, which was a huge issue when it came to MSK topics, right? They tell you that MG patients are going to present with fluctuating ptosis and double vision, bulbar symptoms like dysarthria and dysphagia, and proximal muscle weakness. Symptoms typically worsen with fatigue at the end of the day. Patients may report difficulty in climbing stairs, rising from a chair, brushing hair, and swallowing. Myasthenic crisis is rare, but includes the potentially lethal complication of respiratory compromise and aspiration, because as the muscle weakness kind of reaches the diaphragm, breathing becomes really hard to do. It may be precipitated by medications like fluoroquinolones, trauma, or even surgery. Treatment is with airway management, IV immunoglobulins, or plasmapheresis, and of course IV steroids. The best initial diagnostic test is to do an acetylcholine receptor antibody test. Edrophonium, which is called the tensilon test, is an anticholinesterase inhibitor that can be used as a diagnostic tool because it rapidly reverses symptoms. So if you give edrophonium to a patient, they can do this for you in questions. If you give edrophonium to a patient and things get better for them, that's kind of confirming for you that it is myasthenia gravis, because that's the only time it really works. What's happening in myasthenia gravis is that you don't have acetylcholine receptors, right? There's no acetylcholine receptors, so all the acetylcholine you have doesn't matter because there's no receptor for it to work on. And then on top of that, if you have any anticholinesterase, that's going to kill acetylcholine, so you might even lose acetylcholine. So if you lose both things, the acetylcholine and the acetylcholine receptor, you're really not going to have any function at all. So giving this anticholinesterase inhibitor allows you to have even more acetylcholine, thereby allowing you to use whatever receptors you might even have available. Application of an ice pack over the eyelids may improve symptoms. This test is a board favorite, right? So they really do this in pretty much every question. It's a very common thing. You'll see that they'll talk about a patient who has a lot of ptosis or double vision, right? And then every time they feel that way, that their ptosis is acting up too much, they tend to take ice packs and put it on their eye, and all of a sudden things get better. Right? So this might be like the only symptom they'll tell you, and then they'll ask you, what do you think is the diagnosis, and you'll have to pick myasthenia gravis off of that. an abnormal single fiber EMG and or a decremental response to repetitive nerve stimulation can yield additional confirmation. So here's another scenario they can use in a question. So this is the nerve stimulation test, right, where what they'll do is, you have to remember these people have a lot of acetylcholine but not enough receptors. So when you stimulate one of the nerves, whatever receptors are there are going to get activated, right? Now you're going to run out of receptors. So when you keep stimulating the same receptor, that receptor is no longer going to be sensitive, and the response to repetitive nerve stimulation will become decremental. It'll become weaker responses because maybe there's only 3 receptors as opposed to the typical 100 receptors in the single specific area where you're causing nerve stimulation. And every time you cause nerve stimulation, those 3 receptors are becoming weaker and less sensitive, right? So they become saturated in a sense also. So the response to the stimulation is decreasing. Treatment, anticholinesterase inhibitors. This medication, pyridostigmine, in step 1 it was taught pyridostigmine gets rid of, right, so it's RID, RID, gets rid of myasthenia gravis, which is MG. It's spelled GM here, but think of it as spelled the other way around, and you would remember pyridostigmine gets rid of myasthenia gravis. This thing is used for symptomatic treatment. So you have to remember, questions in CK are going to be very specific on what kind of treatment they're asking you to come up with. They might want symptomatic treatment, they might want long-term treatment to reduce symptoms other than the muscular symptoms, right? So here they're asking about prednisone. Prednisone and other immunosuppressants like azathioprine, cyclosporin, mycophenolate mofetil, all the immunosuppressant medications from immunology, as well as plasmapheresis or IV immunoglobulin, can also be used for treatment. Resection of the thymoma can be curative. Avoid giving certain antibiotics like aminoglycosides and fluoroquinolones and drugs like beta blockers to patients with myasthenia gravis because of their direct and indirect effects on the neuromuscular junction. Right? So your answer is usually going to be between picking pyridostigmine or prednisone. And IVIG is often an answer choice as well because it throws a lot of students off. They don't really consider that as an answer to pick. So myasthenia gravis is much worse than Lambert-Eaton. Now if we look at Lambert-Eaton, Lambert-Eaton is a paraneoplastic autoimmune disorder caused by antibodies directed toward presynaptic calcium channels in the neuromuscular junction. So you're really just affecting calcium channels here, but you do have your acetylcholine receptors, and of course you still have acetylcholine as well. The only issue here that's worse than myasthenia gravis is the cancer that's associated. So here you get small cell lung cancer, right? 60% of cases. Whereas the cancer in myasthenia gravis is just a thymoma, and that's very easy to deal with. You just resect it, no big deal. Lambert-Eaton presents with weakness of proximal muscles along with depressed or absent deep tendon reflexes. Extraocular respiratory and bulbar muscles are typically spared, which is a big difference, right? So you're not going to have the ptosis or the bulbar symptoms they were talking about, like this R3 and dysphagia. Weakness will improve with activity. So the more they do stuff, the better they get. Whereas it was the other way around for myasthenia gravis. Activity was making things worse, right? That's why the nerve stimulation, the repetitive nerve stimulation, was making things worse in myasthenia gravis. Here, though, the more you try doing activity, the better they get. So they improve throughout the day. Here, the repetitive nerve stimulation reveals a characteristic incremental response. Also diagnosed by autoantibodies to presynaptic calcium channels and a chest CT indicative of a lung neoplasm. Treat small cell lung carcinoma because that's the bigger deal than the Lambert-Eaton itself. And then there's this thing 3,4-diaminopyridine or guanidine can be given. Acetylcholinesterase inhibitors can be added to either regimen, but the acetylcholinesterase inhibitors are a bigger deal for myasthenia gravis. Corticosteroids and azathioprine can be combined or used alone for immunosuppression in case where a neoplasm cannot be identified and an autoimmune cause is suspected. So this is going to be probably the hardest type of question you'll get on Lambert-Eaton, where they'll tell you that, they'll tell you enough things in the question for you to know or be able to figure out that it is Lambert-Eaton, but they won't tell you that they found a small cell lung cancer. You, as a clinician, will have to assume, because you always want to assume worst case scenario so you can dodge it, right? You're going to have to assume that the person might have small cell lung cancer because, the risk factor is pretty huge, right? It's not a 10%, it's 60%, which is more than 50, so it's like more than half a chance they have small cell lung cancer. So in assuming they have small cell lung cancer, the question might continue on saying, To treat the patient, we started them on 3,4-diaminopiridine and also give them pyridostigmine. What else should be added to the regimen? The other answer choice would be to pick some immunosuppressive medication like azathioprine. You would have to pick that simply because you yourself as a clinician will assume that they probably also have small cell lung cancer that has yet to be identified. Another way they can word the question is they'll be like, what other tests should be ordered, right? Because the question is basically just going to say what's the next best step in management, and then management can be one of two things: diagnostic management or treatment management. If they're asking about treatment management, then you should add immunosuppressant. If they're asking about diagnostic management, then you should obviously also order a chest CT to check if there's a lung neoplasm, because there probably is, right? You need to uncover it. So that's kind of what we talked about a lot in step 1, where, in the beginning, of course, this was very confusing. The two topics seemed very similar, and the questions often looked very much the same for both of them. So we had to come up with good memorization tools that would help make this topic stick. So when I was trying to come up with things, I used the words that are in here and the names to kind of make better sense out of it. So I wrote here, myasthenia gravis is more grave being a worse problem. You do not have the receptors and it worsens with use. In Lambert-Eaton, something is eating your calcium, decreasing acetylcholine release. Thus, giving more acetylcholine actually helps them a lot. Right? So the problem here is when you lose the calcium was actually necessary for acetylcholine release. So they have acetylcholine and they have the acetylcholine receptors, but they just can't release the acetylcholine. But the more they try to use their muscles, the more calcium comes out, and then things start getting better. So it improves with muscle use. Right? Overall, Lambert-Eaton itself is a very simple and okay disorder. The associated cancer is the one that's a really big problem. And one of the key features in Lambert-Eaton is the autonomic symptoms. Right? So dry mouth, impotence, all of those alpha and beta receptor related symptoms. Those are not things you're going to see in myasthenia gravis patients. However, myasthenia gravis patients had those bulbar symptoms, right? Bulbar symptoms being the dysphagia and dysarthria, all kinds of other things related to bulbar muscles. Those things you won't see in Lambert-Eaton, right? Because, of course, Lambert-Eaton you can eat, but here eating is going to be a little difficult. Difficulty chewing, difficulty swallowing, right? Those are going to be things that are going to be harder. So I basically used the names of the diseases and played off of that to come up with memorization tools that would help make this stick. Now if we come back to first ACK, there's a question up here. So 28-year-old woman, let's take a look at what happened to her. 28-year-old woman comes to the office due to weakness. She, who is 8 weeks postpartum, reports intermittent weakness of the upper and lower extremities. She says, my arms feel weak after carrying the baby for a few minutes, and I can lift him until I rest for some time. Yesterday evening, I couldn't even get off the toilet, but today I feel fine. She has also had episodes of blurry vision. Okay. So far it's not very clear what's wrong with her, but it seems like some kind of muscular problem, and it also seems to be coming and going, right? Because yesterday she had a big problem, today she's fine. Her pregnancy was complicated by gestational diabetes, but she has no chronic medical conditions. She does not take medications, tobacco, alcohol, or drugs. Blood pressure and pulse are fine. Physical exam shows normal pupils and extraocular movements. JVP is not elevated, so her heart is fine. JVP is more about the right heart, so her right heart is fine. Chest auscultation reveals no abnormalities, so all the valves are fine. There's no extremity edema. Deep tendon reflexes and muscle strength of the bilateral extremities are normal. What is the most likely diagnosis? Okay, so they really didn't give much to work off with in this question, but they definitely made sure to choose answer choices that would really be confusing enough. So, of course, 25% of people fell for multiple sclerosis because there were these symptoms that were coming and going, right? And that's a very key cardinal thing in multiple sclerosis. They're relapsing and remitting of symptoms. But multiple sclerosis has other key things that we're not seeing in this patient at all. Like it's very unlikely to really think of multiple sclerosis here. This patient actually has myasthenia gravis. This young postpartum woman has fatigable proximal muscle weakness and intermittent blurred vision, findings suggestive of myasthenia gravis. It is the most common in women of childbearing age. In addition, pregnant and postpartum women are at increased risk for both disease onset and exacerbation. Men are less frequently affected and typically develop symptoms later in life. Bulbar and ocular dysfunction are common. Although exam eventually demonstrates fatigue or weakness with repetitive activity, it is often normal on initial evaluation. And you could tell that the weakness was happening with repetitive activity because her arms feel weak after carrying the baby for a few minutes. So that's a few minutes of repetitive activity. After which those muscles that she was using to hold the baby up started giving away and she needed to rest. Right? So that was the key symptom of myasthenia gravis. And the blurry vision being episodic wasn't because of episodic nerve injury, it was episodic muscle tiring. Right? Her eye muscles got tired, so her vision got blurry. She had to probably rest her eyes, and then her blurry vision went away after resting her eyes. Right? So that's another differential you're seeing in this question with multiple sclerosis as opposed to the other questions we've been looking at. Well, we haven't looked at it, but other questions we mentioned where the differentials are going to be revolving around the other musculoskeletal problems that are up here, right? Fibromyalgia, polymyalgia rheumatica, all of which have their own things that are key. Like polymyalgia rheumatica is an inflammatory thing. There's going to be high ESR and CRP, normal CK, no muscle damage, there's no creatine kinase leakage, and is often associated with temporal arteritis. Right? So it's more common in elderly women. Fibromyalgia is commonly talked about with fibrofog, where it's going to be some young patient, usually again women, who are having cognitive disturbance as well as pain throughout their body, right? Tender points, but all the tests are going to be normal. There's going to be absolutely nothing wrong. So this is more a psychological problem, right? And you can use neuropathic pain agents like gabapentin. Polymyositis and dermatomyositis are actually muscular problems where you're going to have elevated CK. Right? There's inflammation that's actually destroying muscles, and the only difference between the two is the type of CDs and the exact location where the inflammation is occurring. And then dermatomyositis is worse of the two because dermatomyositis has occult malignancy, as you can see in this question, where the patient also has ovarian adenocarcinoma. Right? So they tell you in this question explanation that dermatomyositis is often associated with occult malignancy like ovarian, lung, or colorectal, and non-Hodgkin lymphoma. So I think, let me see, is there a question here? This middle question here is actually related. So this one says, 62-year-old woman has double vision, especially when reading at bedtime. The problem first started several months ago and was intermittent but has worsened over the last 2 weeks and now bothers her constantly. The patient has also developed difficulty chewing and swallowing foods. So those are bulbar symptoms. When you read that, you call that a bulbar symptom immediately. And since they're having difficulty eating, this is not Lambert-Eaton, because Lambert-Eaton you can eat. Right? That's the play on words we use. So this must most likely be myasthenia gravis, where the continued use of her eyes and the continued use of her chewing muscles is causing those muscles to tire out. She usually feels better in the mornings because when you rest you feel better, and continued use of these muscles in myasthenia gravis makes things worse. She has no extremity weakness or sensory symptoms. Examination shows ptosis bilaterally. There is weakness of right eye adduction and left eye abduction. Muscle strength is 4 out of 5 in the proximal muscles, and upper and lower extremities deep tendon reflexes are 2+. What changes to the postsynaptic muscle cell explains the patient's symptoms? So they actually made this question very specific by telling you that the issue is postsynaptic. Postsynaptic issue is myasthenia gravis. Presynaptic, where you can't even release acetylcholine because you don't have calcium, that's Lambert-Eaton. So this one was reduced amplitude of motor end plate potential. Reduced amplitude meaning that when you try activating the nerve, the response you get is not going to be that high. This is just myasthenia gravis. Very very simple, straightforward question. Pretty easy as well. Right, so nothing crazy. The two diseases are only confusing when you are confused about which one is which. Once you figure out which one is which, you're good to go. Another thing that happens in questions is often they'll start off with the associated cancer rather than the muscle. So the question might actually start off talking about a person who's having difficulty swallowing because of the thymoma. Right? So they might have a mediastinal mass that maybe is somehow compressing things in this area, thereby making it difficult to eat. And then that thymoma is where you're supposed to figure out, oh, this person must have myasthenia gravis as well, which also causes difficulty swallowing. Similarly, they can do the same thing with Lambert-Eaton, where they might talk about a person with small cell lung cancer, and then they'll be like, what else should you check for? Well, since 60% of people with Lambert-Eaton get small cell lung cancer, when you find a person with small cell lung cancer, you really want to consider, do they also have Lambert-Eaton? Right? Because when you have small cell lung cancer, you want to treat everything else the patient has to make sure nothing else is making their life worse. And then you start the chemotherapy for the lung cancer. Right? So those are some things you'll have to keep in mind as a clinician when you're dealing with patients. On the side, they have some key facts about things we talked about. So repetitive nerve stimulation reveals a characteristic incremental response in Lambert-Eaton because repetitive nerve stimulation allows more calcium to come out, but shows a decremental response in myasthenia gravis because you only have a few receptors, and every time you stimulate the nerve, those receptors get used up. Right? So that's a great way to figure out which one is which. Anterior mediastinal mass with clinical weakness is thymoma until proven otherwise. Right? Mediastinal masses are very rare out of the blue, so if you do have a mediastinal mass, it usually is just a thymoma. Lung mass with weakness equals Eaton-Lambert syndrome or Lambert-Eaton syndrome in a patient with SCLC, small cell lung cancer, until proven otherwise. So these are some things you want to keep in mind until you've removed the possibility that it's even a possible truth. Right? So as soon as you see these presentations in clinical patients, you need to rule out these problems, and then you move forward to finding out what else is happening. Next thing here is the notorious topic of multiple sclerosis, which was related to the question we just did above, so it's nice that they were all together. You can see that the way CK is organized is different from step 1 first aid, and there's a reason for that, and that reason is also reflecting in the UWorld question we just did, where 25% of people chose multiple sclerosis as their differential answer choice. This is going to often look very similar to the myasthenia gravis and Lambert-Eaton stuff we were looking at. You're just going to have to make sure you can actually see why patients are presenting the way they're presenting. What is the key reason they're having the symptoms they're having? Is it a demyelinated lesion, or is it because their muscles can't really work? Multiple sclerosis is a demyelinating disorder of central nervous system of unclear etiology, but is thought to be immune-mediated. The female-to-male ratio is 3:2, and it is typically diagnosed between 20 and 40 years of age. MS becomes more common with increasing distance from the equator during childhood. Subtypes are relapsing remitting, primary progressive, secondary progressive, and progressive relapsing. You don't need to know the subtypes. It's nice to know they exist, but you don't need to know them like individually. Patients present with multiple neurologic complaints that are separate in time and space and are not explained by a single lesion. As the disease progresses, permanent deficits can accumulate. Limb weakness, gait unsteadiness, paresthesias, optic neuritis, ophthalmoplegia, diplopia, vertigo, nystagmus, sexual and bowel dysfunction, it goes on, pretty much affecting everything from head to toe. Symptoms classically worsen with hot showers, right? That's going to be a really important thing you'll see in questions. Don't mention it that whenever this patient takes hot showers, they feel even worse because the heat from hot showers is kind of messing up the myelin that's being destroyed, right? So myelin and heat, they work together. Myelin is a kind of like a conductive material in a sense, and it's supposed to help conduct electricity quicker. When you have hot showers, a very weird phenomenon takes place where the heat that your body is sensing is also being transmitted through the same myelin, same nerves, same sensory nerves and whatnot, and that myelin stops working very well because it's transmitting those signals of heat. It's a very strange little thing that occurs. Attacks are unpredictable, but on average occur every 1.5 years, lasting for 2 to 8 weeks. Neurologic symptoms can come and go or be progressive. Those with a relapsing and remitting history have the best prognosis. Most accurate tests use MRI and LP as outlined by McDonald diagnostic criteria for definitive diagnosis. So now, this isn't something they talk about very much here. They don't have like a table for it or anything. But you can Google the McDonald diagnostic criteria and you'll figure out what that's about. Generally speaking, let me see something real quick. Let me try to find Let's see if they have a table for this. Well, they kind of do. As this is, let me see. Yeah. National MS Society.org. Oh, they actually haven't updated this. So the last one they have is actually 2017. Let's take a look at it. So it's a pretty big thing. It's very specific and detailed, but you don't need to know it completely. However, knowing these diagnostic criteria is nice in the sense that it helps you kind of see what you'll be looking for. So it's very similar to what they were explaining right here, right? So they just said the people that have unpredictable attacks every 1.5 years and the involvement of everything throughout the body. So if you read what it says, in a person with a typical attack, CIS at onset, you're going to have more than 2 attacks and objective clinical evidence of more than 2 lesions when you do the MRI. More than 2 attacks and objective clinical evidence of 1 lesion with historical evidence of prior attack involving lesions in different locations. Those are 2 different things you can see. Right? And then additional data needed to make MS diagnosis? None. If you see these things, that's enough for you to know it's MS. Right? Dissemination in space and dissemination in time have been met. The point is to meet both of those criteria, dissemination in time and space. Another way you could diagnose it, more than 2 attacks and objective clinical evidence in 1 lesion. If you find that, then what else do you need? Additional data? One of these other things. Either an additional clinical attack implicating a different site, so that's going to be dissemination in space, or dissemination in time where you have symptomatic or asymptomatic MS typical lesions in different places of the brain. Right? So basically what they're doing in this table over here, and they keep doing it, clinical presentation, and then the additional data needed. This is how you're supposed to think, right? When a person comes in with 1 attack and objective clinical evidence of 1 lesion on the MRI, what additional data is needed for you to make the diagnosis? Well, again, DIS, dissemination in space, or DIT, dissemination in time. That's all you're really looking for in all of these. All of these, they're doing the same thing. So that's basically the McDonald criteria for diagnosis of MS. You need the DIS and DIT. Once you find those disseminations, you can confirm it is multiple sclerosis and then start working towards treatment. Right? So again, you don't really need to have the table or anything like that, but the table does a good job explaining to you what the criteria is for you to diagnose somebody. MRI is a diagnostic test of choice, shows multiple asymmetric, often periventricular white matter lesions. So you can see the white matter lesions are along the ventricle. That's what they're talking about with periventricular. So those are called Dawson fingers. You're probably never going to hear that name anywhere, but they have the name for it, so they tell it to you. Especially in the corpus callosum. Active lesions enhance with gadolinium. So gadolinium is actually something you use in MRI. It's like the contrast or whatever material you use to do an MRI. So it's actually called the gadolinium MRI. And when you use the gadolinium, if someone has an active lesion of MS right now, which means they probably have active symptoms of MS, then the lesion areas are going to be enhanced, brighter. CSF will reveal increased IgG index or at least 2 oligoclonal bands not found in the serum. Now, oligoclonal bands, they cite it's not specific, but this really is the only place they'll ever talk about oligoclonal bands. When we were in step 1, I think MS was more of a neuro topic there, so let me see. I have a picture here where we talked about, so here we can see more, this image here is showing you the same periventricular stuff, right, on MRI, the, what do you call it, the periventricular white matter lesions. So that's what you're seeing in this person at a different angle. Same thing here as well, periventricular Dawson fingers, right? And then this image is a U-World image showing you the oligoclonal bands they're talking about. The difference is not extremely clear, but it's pretty clear. So the point is that when you take a normal person's stuff and do the DNA laddering, you really don't see much happening here, right? The lines are very, very confluent. They're all together. But here, the lines are very clear. These are your oligoclonal bands, right? The other protein bands make clear lines at the bottom. That's okay. But there are no clear lines at the top. There's just this one on the top over here, and that's about it. The rest of them are all uniform. But here you can see multiple lines in the middle, right? And those multiple lines at the top of this ladder is proving that you have oligoclonal bands. And oligoclonal bands are pretty much only seen in multiple sclerosis. So although it's not very specific, apparently, it is a multiple sclerosis thing as far as we're concerned, right? Let me see. Yeah, see, here in step 1, they actually tell you oligoclonal bands are diagnostic, right? And MRI is gold standard. So, again, like, it is diagnostic. It may not be specific, as they're teaching here, but it is diagnostic. Or at least 2 oligoclonal bands not found in the serum. Right, okay. But you are supposed to find oligoclonal bands. And when you find oligoclonal bands, that's when you know it is multiple sclerosis. So I'm not exactly sure what they're trying to say in this last sentence here. Treatment, acute exacerbations versus disease-modifying medications. Now, the disease-modifying medications are things that are not going to help with acute exacerbations. So if someone today, right now, has an MS exacerbation, you need to give them something to help them with that acute exacerbation. High-dose IV corticosteroids. That's it. Plasma exchange in patients who do not respond to corticosteroids is the second option you could use. We give them the prednisone, high dose, right away, and the acute exacerbation will resolve, by the end of the day, by the end of the next day. And then you also need to put them on disease-modifying medications for long-term, because the attack may not go away. And that includes a bunch of medications you may not have heard of before. So the first thing they talk about, ocrelizumab. This is for progressive MS. So you remember there were different types of MS. So if someone has progressive MS, that means that the dissemination in time and space is getting worse. Right? So every time they have an attack, the presentation is worse. Hence why it's called progressive. So for them, you give them ocrelizumab. Immunomodulators for relapsing remitting MS can decrease the number of relapses. Treat with injectable ABCs. Interferon beta, which is called Avonex. Interferon beta 1b. So you can see what the ABC is. Interferon beta 1a, interferon 1b, and then copolymer 1. So that's what the ABC is, and this was never mentioned back in step 1. So step 1 talks about treatment, and they mentioned that, a bunch of different medications, but they don't really break down the way it's being broken down here, ABCs, right? So that's something you'll have to keep in mind. Like there's a lot of things that get tested on this, for medication-wise, treatment-wise, management-wise. There's so many different things you can be asked, so you need to be ready with that. So the injectable interferon alpha, interferon beta 1a, interferon beta 1b, and copolymer 1 are going to help. Now, a number of oral small molecules and infusions of monoclonal antibodies are more common. Symptomatic therapy is crucial and includes baclofen for any spasticity the patient might have, cholinergics for any urinary retention they might have. So if they can't urinate, then urinating is a parasympathetic thing. You need acetylcholine. So you give them a cholinergic medication that acts like acetylcholine to help them pee. Let me see. And then carbamazepine or amitriptyline for painful paresthesias, and antidepressants for any clinical depression the patient may be presenting with. So multiple sclerosis questions, you can actually make like an entire 40-question block of just multiple sclerosis questions, because there's so many different things, different presentations, and different related comorbid conditions that you can get tested on. Step 1 had like endless URL questions on multiple sclerosis. Let's take a look at some of these here to really get a good understanding of how this stuff presents. First one, 32-year-old woman comes due to left eye pain accentuated by ocular movements. She has periodic dimming of vision in the same eye. She has had several such episodes over the last month, most often after a hot shower or intense workout. A year ago, she had an episode of numbness and tingling in her left arm that resolved spontaneously. Ophthalmologic exam shows swelling of the optic disc. Neurologic exam shows a mild intention tremor and broad-based gait. What is the most likely cause of her current condition? demyelinating plaques. Like, it was so obvious this is multiple sclerosis. One of the key differences you're seeing here compared to myasthenia gravis was she had dimming of vision. Dimming of vision means the optic nerve is not sending signals very well because it's losing myelin. As opposed to blurry vision, which is occurring because the muscles of the eye are not contracting accurately enough because they're tired, aka myasthenia gravis, right? Other correct answers for this same exact question, worded in different ways, were reduced saltatory conduction, because that's what myelin does, or oligodendrocyte depletion, which is what occurs when you lose the oligodendrocyte myelin. A 23-year-old woman is referred to a neurologist of recent onset diplopia and ataxia. A year ago, she experienced numbness and paresthesia involving her left leg that have since resolved. MRI of the brain reveals several areas of T2 hyperintensity. So T2 was too bright, right? That's what we talked about with MRIs. So there's some bright, and they help you out in this question by telling you hyperintensity, consistent with axonal demyelination. Obviously, a diagnosis of MS is made. What neuronal property is most likely to decrease as a result of demyelination? And then these were the answer choices. Length constant, which is also called space constant, spatial summation, temporal summation, or the time constant. What's going to decrease? You always want to make sure you underline in such questions, underline what the actual question is. Right? There are often questions that are going to ask you what's going to increase, what's going to decrease, and then you might come up with your own question in reading that problem and answer your own question, which would be the wrong answer choice, right? So you're looking for what's going to decrease. Some of these things are actually going to increase. What will decrease is how far a signal can go without the myelin. So that's your length constant. So there was a huge issue in step 1 where they talked about the distance over time, right? Distance over time, or length over time equation to help you understand how the physics of myelin is working here. It's not that complicated. We all learned at some point the basic physics equation: velocity equals distance over time, which is why all things are measured when they're moving miles per hour, right, or kilometers per second, meters per second, depending on where you live. But it's always distance over time. So now in these people without their myelin, things are going to take a longer time and travel a smaller distance, right? So the distance number decreases and the time number increases, overall making the velocity decrease, right? And the signal is going to travel slower. And that's exactly what occurs in multiple sclerosis, right? So you just want to make sure you understand that. This isn't something you need to memorize. It's practically commonsensical. It's just something you want to put into words, and then you kind of see it and you won't forget it anymore, right? So velocity does equal distance over time, and you're not going to travel a far distance, and it'll take longer time to even travel any distance because you lost the myelin. Myelin, remember, was this thing. So remember the way myelin was that you might have this long nerve, and then you have areas that are myelinated, right? Areas that are myelinated, and in between those areas of myelination were the things called nodes of Ranvier, right? The nodes of Ranvier. So the way that electricity was traveling was that it was actually jumping from one node of Ranvier to another node of Ranvier, which is making the travel much quicker because you're saving a lot of time by not having to travel in a straight line going through the entire signal thing, right? So essentially, what you can imagine is you can cut these areas out. So the nerve length actually became smaller, right? So it was just this portion plus this portion plus this portion. So you see, if I connected these 3 lines, it would be a lot smaller than this entire portion from here to here. And that's what myelin is there for. It's there to reduce the distance you're traveling and make the travel quicker. Right? So you lose that. You lose that in multiple sclerosis, and everything starts getting really bad for them. Oligodendrocyte depletion was often an answer choice. Periventricular inflammatory cells was often an answer choice. Even NBME has really weird wording, but it makes it pretty clear that the question is about multiple sclerosis. This is NBME 18. 21-year-old woman comes to the physician because of a 10-day history of difficulty walking. 2 years ago, so you can already see they do a pretty good job in most questions with the dissemination in space and time. Or if they don't do that, then they give you exact diagnosis. They'll tell you what they see on an MRI, for example. So this is dissemination in time. 2 years ago, she had loss of vision in the left eye, which improved over 2 months. Neurologic exam shows decreased visual acuity in the left eye. with pallor of the optic disc. She has pass pointing on her finger nose test. So pass pointing on a finger nose test means that when I tell you to bring your finger to the nose, you miss. You kind of just miss. You couldn't point at your nose because your vision is so blurry. So you're pointing at another nose that isn't really there because of the blurred vision. She has a broad-based gait. MRI of the brain shows lesions in the white matter of the cerebellum. Which of the following best describes the pathogenesis of the disease in this patient? So here the answer was just B. CD4 positive T lymphocytes activated by myelin basic protein. This is one of the weirdest answer choices I have ever seen regarding multiple sclerosis. All right. So this was actually very hard for students because usually you only mention CD4 versus CD8 positive T lymphocytes when you're discussing the topic of dermatomyositis versus polymyositis, where polymyositis is poly, so that's the one that has the CD8 positive T lymphocytes, right? It's very weird answer choice, but this is actually what's happening. See, CD4 T lymphocytes are the helper T lymphocytes, and those are usually the ones that activate for everything. CD8 lymphocytes are cytotoxic lymphocytes that are killing things, and that's not what's happening here. You know, CD8 lymphocytes are rarely ever the correct answer. It's definitely a thing for polymyositis, but rarely ever the correct answer in any autoimmune condition. And I guess it kind of helped that they're talking about an immune response against myelin basic protein because you are killing myelin, but it was still a very difficult answer choice for a lot of people to pick. However, not so much to me, to be honest, because at least the other answer choices were not that obvious, and they were definitely wrong. The other answer choices made no sense. All right. So that's basically many different presentations here in step 1. In CK, we have this question. 35-year-old woman comes to the office due to a 2-day history of weakness in her right hand. She has no other symptoms but reports a transient episode of lower extremity numbness that resolves spontaneously. Okay. She has a history of herpes labialis and takes valacyclovir as needed. She recently began taking a vitamin D supplement after she was found to have low serum vitamin D levels. Other medications include oral contraceptives. She has also received annual influenza vaccines. She does not use tobacco, alcohol, or drugs. Family history is going to have diabetes and hypertension in her dad, but not her, so I'm not going to underline those. This was a BMI. BMI is 28, so that's not bad at all. We really only ever care about BMI when it's over 30. Exam shows mild spasticity in her right hand. MRI of the brain is given, and you can already see the Dawson fingers, right, the periventricular white plaques. And here you immediately figure out it's multiple sclerosis. What is most strongly associated with her condition? And this is where the question got really funky, right? Because it was very unexpected that they would have this as an answer choice. Vitamin D deficiency. Right? Whereas 28% of people chose recurrent HSV infection, but recurrent HSV infection is not exactly her problem. Her problem is HSV reactivation, not recurrent HSV infection. Her hand weakness, a prior episode of leg numbness, and white matter lesions on MRI likely indicate MS, right? The MRI is showing you dissemination in space, 4 different places, and then the fact that she's had symptoms occurring disseminated in time kind of confirmed to you it's MS. But how is this related to vitamin D? So diagnosis is largely clinical, but supported by neuroimaging with demarcated plaques of demyelination in the periventricular white matter and CSF, showing oligoclonal immunoglobulin bands. It has a genetic predisposition that is seen more frequently in patients with major histocompatibility complexes such as HLA-DRB1. In addition, patients with vitamin D deficiency are at increased risk of MS development. Other risk factors like geographic location, colder climates, reduced sunlight exposure are likely related. Epstein-Barr virus infection and smoking are also associated. So this question did a really nice job bringing into light a couple new things that are not mentioned anywhere in the book. That's kind of what the point of these Q banks is, right? For completeness purposes. But it should have been mentioned in the book, which is why I put it in the book, right? This stuff should be in the book. It's not something you would memorize. It's just that if you ever see this in a question, it will ring a bell. The vitamin D deficiency will ring a bell. This question did a terrible job verbally showing you that this is MS, but then the MRI made it super clear, so that's why the wording of the question was so unnecessarily vague, right? A vague question with a solid MRI, you don't even need the question. I could just give you this MRI and you're immediately going to pick multiple sclerosis because you can see the 4 disseminated periventricular Dawson finger plaques. And you're done. So this taught you a couple more things. HLA-DRB1, vitamin D deficiency, and Epstein-Barr virus, as well as smoking, which is inflammatory, are all related to things that can also somehow trigger multiple sclerosis. Pregnancy may be associated with a decrease in MS symptoms, and for optic neuritis, give IV, not oral corticosteroids. So these are two pretty nice key facts that can also be relevant in questions. You could get a pregnant patient, since MS is more common in women. You could have an MS patient who didn't have a single episode during pregnancy and was actually feeling better during pregnancy, and then that might be their hint telling you that the patient has MS, something stupid like that. Next topic here, Guillain-Barré. Now, Guillain-Barré, of course, with the ascending paralysis, is most significant for patients who don't really deal with it, patients who don't come in for treatment, because then it can ascend to the diaphragm, they can die without being able to breathe. Acute, rapidly progressive, demyelinating autoimmune disorder of the peripheral nerves that results in weakness, also known as acute inflammatory demyelinating polyneuropathy, associated with the recent Campylobacter jejuni infection, viral infection, or influenza vaccine, in extremely rare cases. So rare that it shouldn't even be mentioned or ever tested, but of course it will be tested. Approximately 85% of patients make a complete or near complete recovery, can take up to 1 year. Mortality rate is less than 5%, but people do die. Classically presents with progressive, symmetric, ascending paralysis, and areflexia. So like in their legs, the reflexes, the deep tender reflexes in the legs are going to be low. In severe cases, paralysis can progress to involve the trunk, diaphragm, and cranial nerves. Autonomic and sensory nerves may also be affected, leading to glove and stocking distribution paresthesia, so in the hands and the feet, and autonomic dysregulation. Evidence of diffuse demyelination is seen on nerve conduction studies, which showed decreased nerve conduction velocity, supported by a CSF protein level more than 55, with little or no pleocytosis. So this is called albuminocytologic dissociation, which is commonly an acid choice in step 1. And you can see this as an acid choice in CK as well, right? So albumin and cytologic dissociation, you have a high CSF protein, but there's no pleocytosis occurring, right? Remember that ascending paralysis with normal CSF findings without autonomic dysfunction is characteristic of tick-borne paralysis, not Guillain-Barré. Right, so this is going to be like a differential you'll have to make. Right, so CSF findings of high protein are what point at Guillain-Barré. If you have normal CSF findings with ascending paralysis, it's probably someone with tick-borne paralysis. Right? And then, of course, keep in mind that Guillain-Barré is presenting with autonomic dysregulation. So if you don't see autonomic dysregulation, that can also be tick-borne paralysis. Treatment: frequently monitor maximal negative inspiratory force, maximal negative inspiratory force, and vital capacity to determine whether patients should be admitted to ICU for impending respiratory failure. Basically, monitor their lung capacity functionality. Plasmapheresis and IVIG are first-line treatments. Corticosteroids are not indicated. Aggressive physical rehab is imperative. Right? This is an image here showing you that you get a person with infection. So this is a squiggly infection because this is Campylobacter jejuni, which is a squiggly bacteria. After getting an infection, you get immune activation. Immune activation causes immune clearance, but then 1 to 2 weeks later, you get an autoimmune activity against your own myelin because of molecular mimicry. So the things that are on Campylobacter jejuni, those antigens, are very similar to some antigens that may be on your myelin, and you end up having to kill your myelin. Right? That's pretty unfortunate. So that's what happens in these people. So getting infection with Campylobacter jejuni is a pretty significant deal. Very problematic deal that you really want to avoid. Here they talk about the 4 A's of Guillain-Barré: acute inflammatory demyelinating polyradiculopathy, ascending paralysis, autonomic neuropathy, and then the albuminocytologic dissociation, where you have increased albumin in CSF, but no cytologic cells. This question is exactly about that. So a 12-year-old boy, a young boy, is brought to the emergency department by his parents as he cannot walk anymore. He has had pins and needle sensation and weakness in both feet for the past few days. This morning, he could not stand or move his legs and has bilateral thigh pain. 2 weeks ago, he had a febrile diarrheal illness, which is Campylobacter jejuni. It causes bloody diarrhea. that resolved on its own. He has had no headache, nausea, vomiting, or recurrent diarrhea. He and his family are vegetarians, and they recently visited a petting zoo. He has no significant past medical history, and vaccinations are up to date. On arrival, blood pressure is high, and everything else is pretty much okay. Physical exam shows symmetric flaccid paralysis of the lower extremities and absent ankle and patellar reflexes. Sensation is intact to light touch in both legs. Upper extremities are weak and hyporeflexic. No photophobia or nuchal rigidity, so it's not related to Neisseria. What structure is primarily impaired in his condition? The nerve fibers, peripheral nerve fibers, right? GBS, Guillain-Barré syndrome, is an immune-mediated polyneuropathy caused by demyelination of peripheral nerve fibers. Most patients have a preceding respiratory or GI infection, like C. jejuni in this patient, with recent direct contact with animals, which then triggers an initial immune response due to the molecular mimicry we just looked at. These antibodies are then redirected toward cross-reacting antigens on myelin or axons, a process known as molecular mimicry. Motor nerves are also most commonly affected, but sensory and autonomic nerves may also be involved, hence why you have autonomic neuropathy. Presentation includes ascending weakness, often accompanied by paresthesias and neuropathic pain. Treat with IVIG or plasmapheresis, and most kids fully recover. But what a terrible consequence of a simple zoo visit. Now, this may seem exaggerated, but this is actually a very common presentation. This is exactly how this occurs. So you have to be very careful. You gotta be very careful. You can't get Guillain-Barré syndrome because you just don't want to get. You can't get C. jejuni infection. Avoid that in any way whatsoever. Right. See, and then the last one for demyelinating, ALS. Now, the various demyelinating lesions in step 1 were all talked about together. I think at the end right here somewhere. Yeah, these things, right? Spinal cord lesions where you have different kinds of demyelinations that can occur due to various different reasons. And ALS is here as well. This was a nice page because it did a good job showing you where on the cross-section things are occurring, and then you need to know what tracks are in each of these areas, right? What are in these areas that are going to get affected. So in ALS, this is a chronic progressive degenerative disease, usually of unknown etiology, that is characterized by loss of upper and lower motor neurons, also known as Lou Gehrig disease in the United States and motor neuron disease in the United Kingdom. ALS has an unrelenting course and almost always progresses to respiratory failure and death, usually within 5 years of diagnosis. Men are more commonly affected than women, and onset is usually between age 40 to 80. Presents with asymmetric, slowly progressive weakness affecting the arms, legs, diaphragm, and lower cranial nerves. Some patients initially present with fasciculations. Weight loss is common. Associated with upper motor neuron and lower motor neuron signs, sensation, eye movement, and sphincter tone are generally spared, and this is very critical, very important. We're going to see why. Emotional lability is also a common feature. Diagnosis pretty much is going to be clinical. The presentation is going to be all you're going to need. Bulbar involvement suggests pathology above the foramen magnum and generally excludes the most common differential diagnosis, cervical spondylosis with compressive myelopathy. This is another asterisk you're going to see actually. Cervical spondylosis with compressive myelopathy. Spondylosis is where the cervical bones become really thick, and then the nerves that are supposed to be coming down those bones from your brain are not going to really make it down too well. And then, of course, you're going to get all kinds of symptoms from that. But if there's bulbar involvement in the patient, where the patient is having difficulty swallowing or moving their tongue, then the pathology must be above the foramen magnum, which is way above where cervical spondylosis can occur, because it's cervical. Cervical spondylosis happens in the cervix. The cervical area. Foramen magnum is way above there, so if you have problems in the foramen magnum, that's probably ALS. EMG and nerve conduction studies reveal widespread denervation and spontaneous action potentials. Such studies are principally performed to exclude other demyelinating motor neuropathies, but usually you won't need to do it. So if you really think there's some other diagnosis, then you want to exclude that diagnosis with the nerve conduction. CT or MRI of the cervical spine is done to exclude structural lesions such as cervical spondylosis, especially useful in those without bulbar involvement. So there's going to be two types of patients with ALS. One with the bulbar involvement, which makes it pretty confirmed that it's not the spondylosis, so it is ALS, or the ones without the bulbar involvement, so they don't have any oropharyngeal problems, then you need to do the CT or MRI. Most likely just do a CT, it's quicker and easier and cheaper, to confirm it's not cervical spondylosis. Right? You usually want to go with CT if you have the option of CT or MRI, because MRIs are a very big bill. So you don't want to bill patients for things that they really didn't need to pay for. Down here we have a question where, interestingly, it's a female patient. So, 65-year-old woman comes to the office reporting progressively increasing orthopnea, daytime fatigue, and morning headache for the last month. She has had no chest pain or problems with swallowing or speech, so no bulbar symptoms. Medical conditions include MI, diabetes, hypertension, and so they actually tell you directly in this question she has ALS. Alright, that's really interesting. The only other thing I would highlight in this question was the morning headache they mentioned, because we've done that already, right? We saw earlier when we did the headache and seizures that the morning headache was a very unique thing, not a very common thing. Vitals are fine, pulse oximetry is fine, BMI is fine. On the lower end, but pretty normal. Exam shows normal JVP, clear lungs, and normal heart sounds, no peripheral edema. Neurologic exam is exactly as we would expect because, she has muscle atrophy and stuff, unchanged from her last 2 months because she has ALS. Labs are also pretty normal. What is the most appropriate next step in her management? Well, this question actually caught a lot of people off guard. I don't know why I didn't put percentage here. I remember, it's coming back to me now, I remember seeing this. This was a very interesting, so this is a very interesting mechanism of asking a question. It's a psychological gameplay with your mind. What they do in this kind of a question is they tell you all the answers you could possibly think of. Right? When you were reading the question, you might have thought this is ALS. They put ALS in the question. As they were going along, you might have thought they're going to ask you about something regarding neurologic exam. They put that in there. Then you might have thought they're going to probably do something else where they're going to check for something. They did all the checking. So everything you could have possibly thought of was already being done in the question. And that always sucks when that happens, right? It's probably something you've already noticed where you were reading a question and then you were like, oh my god, I bet you the answer is going to be about X, Y, and Z. Turns out, as you kept reading the question, they mentioned X, Y, and Z in the question. And then you give up all hope and then you read the final question and you're like, what the heck is this about? So what is the most appropriate next step in her management? Where she has progressive ALS that is getting worse, essentially. Non-invasive positive pressure ventilation was the only feasible answer choice that was worth picking. There were a bunch of other answer choices, but they were irrelevant. Some of them were, I remember one answer choice was to do the CT, but you didn't need to because she's already diagnosed. Her diagnosis is already given. You don't need to order any diagnostic tests. You need to do management tests to keep her alive. This patient with ALS has manifestations of early respiratory insufficiency. Patients with ALS most often die of respiratory failure, which is caused by diaphragm atrophy, weakness, expiratory muscle weakness, and bulbar weakness. Because gravity is not assisting with lung expansion, respiratory symptoms are often more pronounced when patients are supine. Sleep further contributes to respiratory insufficiency because the accessory respiratory muscles are less active during REM sleep, and relaxation of the weakened upper airway musculature results in airway collapse and obstruction. Thus, early respiratory insufficiency may manifest as orthopnea and appear similar to obstructive sleep apnea. So she came in complaining of orthopnea and morning headaches. The morning headaches are even relevant here because she's not getting enough oxygen to the brain. So the morning headache may be related to some level of decreased cerebral perfusion. Non-invasive positive pressure ventilation improves respiratory function by opening the upper airway and providing positive and expiratory pressure to improve atelectasis. NIPPV is considered first-line therapy for ALS patients with respiratory insufficiency. Once again, something that UWorld is teaching, but is not mentioned here, right? You do see a little bit of it here, but not really. They don't mention NIPPV. Look, treatment just says give riluzole, which could delay disease progress by decreasing glutamate. You could use edaravone, a new medication for advanced ALS, but we don't know much about it. And when I googled it, it gave some information, but not too much. Let me check. Actually, that was a long time ago. Let me check what they have about it now. Edaravone. Sold under the brand name Radicava and Radicut. Used to help with recovery following a stroke and to treat ALS. Both things. Interesting. Yeah, I mean, they have a whole website for Radicava, a pharmaceutical website for Radicava, and apparently a lot of patients are using it, but not for ALS. Mostly it's being used for recovery from a stroke. But it does give patients with ALS a chance to slow the loss of physical function. Right? ALS is basically a death timer, unfortunately. There's no surviving ALS. Your patient with ALS will die, but you can give them these medications to give them more life. Maybe they need to see their child's wedding or something, and they can prolong their life for as long as possible. And most people want that because the conditions you go through while living with ALS isn't that bad. If you have a condition where you're dying and you're going to die, then you want to die right away because you don't want to suffer anymore. There isn't too much suffering in ALS per se. And one of the key things that were spared, the urinary thing, that was pretty critical here. So, they highlight that here as well. No sensory or bowel bladder deficits. Alright? So if you get a patient who does have sensory or bowel bladder deficits, then it's not ALS. You can immediately cancel out ALS as an answer choice. ALS is just muscular. That's it. It's just about muscle. Can be caused by defect in superoxide dismutase 1, which is another thing the CK book didn't mention, and it's pretty much fatal. But it's just muscle. It's just muscle. No sensory or bowel bladder deficits. Right? Very important to understand that. And that's going to be something that will help you differentiate from other things. Like, you see this region that this is covering, right? It's similar to this region, complete occlusion of anterior spinal artery. Right, where look at why there's no sensory deficits. What is this region? This region back here is your dorsal column. Right, that dorsal column region is the gracilis and the fasciculus for the arms and legs. It's not going to be affected. And then the spinothalamic tract. The spinothalamic tract is actually outside of these red dots. It's not in the red dots. So the spinothalamic tract for heat and temperature and all that stuff, that's also not going to be affected. Right, but the what do you call it? The corticospinal tract, that is in here, and your upper motor neuron stuff and lower motor neuron stuff is just related to neurons not sending signals correctly, right? So you're going to see all of that in these patients, but there's a clear difference between these two guys, right? Because in this guy over here, you will have, they're going to tell you here, loss of pain and temperature. Right, loss of pain and temperature. So that's one of the key differentials right there. This is often the sequela of aortic aneurysm repair. CK no longer asks questions directly about aortic aneurysm. So if you look at CK questions for aortic aneurysm, when you do your CK cardiology Q banks, you'll see that there's two types of aortic aneurysm questions. One is going to be the elderly patient who has smoking history, came in today for general physical exam, hasn't seen a doctor in a long time. What are some things you should check for? You should check for their abdominal aorta, right? Is it pulsatile? Is there a brute? That's one type of question, to see if you even have that knowledge, and that's a very common general knowledge, so everyone should know that. Elderly white man, especially white man, with smoking history, check for the abdominal aorta. Then you have the other question where something is being done and then some kind of presentation is occurring now, and they'll be like, what the heck do you think happened? And you need to understand that whatever happened was probably related to an abdominal aortic aneurysm, right? So this is one of those case scenarios where you might have a patient with aortic aneurysm and then they repaired it, right? And then part B, the next question is going to be like, what happened to the patient now? You repaired it and all of a sudden they have some weird upper motor and lower motor neuron deficits. What the hell happened? Well, you must have injured the anterior spinal artery in your aortic aneurysm repair moment. So there's a lot of weird interconnections that occur. Questions love messing around with these interconnections. you don't have to have it perfectly memorized as much as you really need it to be something that sticks to you when you see it in a question. You know, it should come to you, it should ring a bell, and you should be able to evaluate it. All right. So that's kind of what we're seeing here. Pretty good stuff. And then in the next session, we'll move on into the big topic of dementia.